Saturday was graduation day for a new crop of Mayo Medical School graduates, coming in a time of looming doctor shortages and revolutions in healthcare. To discuss that, we're joined by Dr. Gerardo Colon Otero, medical oncologist who practices gynecological cancers and Vice Dean of Mayo Clinic, Alix School of Medicine. Welcome.
Welcome. Thank you so much for having us.
Mouthful. I'm glad I got through it. And a recent medical school graduate, Dr. Yeonsoo Sara Lee, soon to be a practicing urological surgeon. Good morning.
Good morning. Yeah, not quite practicing, but excited to enter residency at Mayo Clinic for urology.
And that's a long process, as you were saying.
So, yeah, it is.
So you just completed, and congratulations, you just graduated from medical school. But that goes, for people who aren't familiar, and I'm not all terribly familiar, you then go into this lengthy residency. What does that entail?
Yeah, absolutely. I wasn't familiar with it until I applied to medical school as well. But essentially, that's 4 years of college. I took some time in between because I wasn't pre-med in college, and then 4 years of medical school. And then depending on what specialty you choose, often between 3 to 7 years of training in your chosen specialty.
And you will be practicing urological surgery, which not a lot of women in that field. So how did you end up there yourself?
Yeah, kind of like I said, I didn't know very much about medicine until I started going into it. And I think that was a really interesting process and so much to learn about different specialties. So I came in with a really open mindset. I'd worked in women's health before. I'd worked in infectious disease before medical school. So thought maybe I wanted to practice medicine, which is different in a lot of communities to surgery. But the first time I stepped into an operating room was basically in medical school, and I thought, what a special privilege to be able to care for patients using my own 2 hands, being able to see what's going on, kind of like being someone who sees a problem and fixes it in that moment. So then became curious about surgery, and there are whole fields dedicated to different types of surgery in different parts of the body. Obviously, we know about neurosurgery or cardiothoracic surgery, but there are other fields that are less well known, like ENT, which is ear, nose, and throat surgery, or urology, which is surgery in the urological organ system, so your kidneys, your bladders, your urethras, and that's not really talked about as much. So when I found out about this field, I thought, well, why don't people talk about it? And it was really interesting to me because it's kind of a taboo part of the body to talk about, and women aren't as well represented in this field. So that's kind of why I got interested.
I recently interviewed another female urologist, and we were talking about just, how unusual it is sometimes for a woman to be in that field. Why do you think that is? Is it because it's often thought of as, your clientele is primarily male and maybe that's a little awkward?
Well, I think there are a couple of different factors. There are still fields in surgery where women are severely underrepresented, like orthopedic surgery or neurosurgery. And I think that certainly applies to urology as well. I think you kind of hit the nail on the head. And a lot of people think of urology as a very male-dominated and male treatment-based specialty. So there's definitely still that. And I think there's a little bit of a paradigm as well. There's gynecology, which is kind of the surgical counterpart to urology in terms of women's health. People often think that women will be treated in terms of urology-based conditions by gynecologists as well. And there's definitely some overlap there.
Interesting. So Dr. Colon Otero, I want to bring you in. The challenges of medical education today are really so varied, and a lot of them are quite difficult. There's an enormous amount of information out there in the world that's available. It would seem that going through medical school would get ever more complicated, ever longer. How does a medical school manage with their students to handle the volume of information and just the revolution in the availability of that information and the technology that's available?
You're absolutely right. Medical knowledge has increased dramatically, and with that, there's a need for more learning, and it's a challenge for medical school education to incorporate all those aspects that are needed to create a physician that will be able to be a competent physician. The medical education process, the medical school is just a part of it. As Sarah, for example, is going into residency to become a urologist, and as medicine has grown more and more, there's more and more subspecialization. So a lot of the knowledge that is acquired and the ability to care for patients and develop the dexterity in surgery and so forth is developed during residency. So we concentrate on the basic knowledge that the students need to become a physician, but a lot of the training into their subspecialty happens then during residency.
And so what is the greatest need right now in terms of the kind of physicians? We hear a lot about, physician shortages, particularly, with people who cater to perhaps, geriatric populations, but also pediatrics to some extent. Where do you see the greatest need in terms of, physician shortages?
Yeah, I think physician shortages exist for all specialties, not just primary care, but also all specialties. There is shortage. It's estimated in Florida, for example, that by 2030, there will be a 22,000 shortage of number of physicians that are needed for serving our aging population and the population that is increasing in Florida. As medicine has progressed, there's more and more subspecialty and more need for subspecialists as well. So there's a need primary care, particularly in rural areas, and also specialty care in all areas, including urology. And as Sarah mentioned, there are some areas in medicine and surgery in particular where there's significant underrepresentation of female physicians too.
And so why is it that there is a physician shortage? I mean, I think obviously there's a lot of costs associated with medical school. Is that the primary hurdle? Because, I mean, it's a very respected tradition, profession. I would think it would draw a lot of people.
Yes, and there's a lot of interest and a lot of applicants to medical school, and not all students who want to become physicians are able to get into medical school and get a medical school education. Part of this shortage, I think, happens at the level of the residency, or what we call graduate medical education. There's probably a need for more positions in graduate medicine, more residency positions, so that the students can then become family physicians, internal medicine doctors, pediatricians, and subspecialists. So there's a need for that in the state of Florida and throughout the country.
You mean that students who graduate from medical school, there isn't availability for them to be residents to kind of have that next step?
The positions are available, and most of them end up matching at a residency through a matching program. And there are international graduates who also compete for those positions. And about this year, last year, 50% of the international graduates were able to get a residency positions. But when you look at the physicians' needs for the next 10, 20 years, there will be a need for more of those residency positions, and as well as more need for medical school students.
But I guess I'm not clear. What do you think explains the shortage? Is it that people aren't able to get into medical school just because of the academic side, or they're not able to get in because financially, or?
I think there's need for more medical schools or medical school medical positions for medical students, but then also a need for more residencies as well.
And perhaps that shortage is also driven by the fact that our population is aging and that people get sicker as they get older.
That's correct. Yeah, there's more need for more physicians as the population ages. So there's then a need for more physicians coming into the pipeline.
Dr. Lee, you said that you had some background in women's health, but you also had some background in public health and the needs of underserved communities. You did some work abroad. Tell us a little bit about how you came into this, what that work was and how that sort of steered where you ended up.
Yeah, absolutely. I mentioned earlier that I wasn't a pre-med student in college. And during that time, I actually studied disease ecology or ecology and evolutionary biology. Thought I wanted to become a fieldwork researcher. So going out into the field, the rivers, the lakes, collecting my own samples, and doing kind of environmentally science-based research. So I've always had a love for asking questions, trying to use my own hands to figure out the answers. And when I graduated from college, I took a research fellowship, and I did that in Brazil, in the Northeast, in a place called Salvador. And it was really beautiful. I learned a lot. And essentially, the goal there was to go and understand disease burden, or how much disease there was of a specific type of rat-borne illness, leptospirosis. So if malaria is carried by mosquitoes, or leptospirosis is carried by rats. And in that area, unfortunately, because of socioeconomic reasons, there were also lots of rats. And so I got there and I started studying the amount of bacteria carried by those rats in rivers, in sewage, in dirt, in rainwater, and was really enjoying like the ability to understand the intersection of public health and medicine and environmental science. But once I got there, people kept on asking me questions like I was a doctor because I was wearing a lab coat. And you had to do that because people needed to recognize that you were a scientist when you were entering those areas. Otherwise, a foreign face could be like a source of suspicion. And people would be like, "Hey, doc, do you know what to do about this? My grandma's not doing super well." And obviously, I had no idea, and so I wasn't going to answer any of those questions, but kind of planted the seed. I'm here doing research and I love doing it and it satisfies my curiosity, but what am I going to do with it? So when I asked some of my research advisors, hey, do you have any advice on how I can translate some of the research I'm doing to actual care for humans? My research advisor was an MD, PhD, and he said, well, you should consider getting an MD. It will give you the power and the skills to be able to do the research that you want to do, but it sounds like you want something a little bit more hands-on. So that's kind of the tie or the draw to medicine for me.
And did your counselor say, P.S., that's 8 more years of school?
No, they didn't, but I think I felt really well supported during that time. And I've always been kind of a believer of, even if it takes a really long time, as long as I'm enjoying the process, it's just another way to learn.
If you're just joining us, we're talking about meeting the needs in communities with health disparities. You can join our conversation live on air by calling 904-549-2937. You can also email firstcoastconnect@wjct.org, or you can reach out on social media. Dr. Colon Otero, the Mayo has sort of an interesting model for medical school. Dr. Lee just graduated from the Florida campus, as it were, but it requires a bit of exploration at other Mayo facilities. Tell us about that arrangement and why is that?
Yes, the Mayo Clinic Alix School of Medicine is a national school with 3 campuses. So students who are interested in studying medicine at Mayo apply to the medical school and they express their interest into which of the 3 campuses they would like to matriculate. So those who choose Florida as their number 1 choice, those applications are reviewed by a Florida committee and they're interviewed here and selected here. We usually get about 500, 600 applications for 12 slots. This is in its 7th year right now for the Florida campus. Nationally, we get about 5,000 applicants to all 3 campuses. So the students who are selected to the Florida campus spend their first 18 months, 24 months in Arizona or Minnesota, and they then move to Florida to complete their medical education, and they graduate from our Florida campus. So we just celebrated our 3rd graduation with Sarah's class this year.
This last weekend. And so what does that kind of split facility model bring to students?
So the student, Sarah, for example, spent her first 2 years in Arizona, in the Arizona campus. So the students are exposed to different communities and learn from, they benefit from the national stature of Mayo Medical School. So in Florida, we have 1,000 full-time faculty and residents and fellows. The same number in Arizona, in Minnesota, about 2,000, 3,000, 4,000 full-time faculty and fellows. So they get exposed to different communities too. In Florida, we partner with the excellent health systems that are in Florida, including Baptist Wolfson, Nemours Children's, the Navy Hospital. So they get exposed to different environments and different populations, and that just strengthens their medical education.
I want to ask you a little bit about the research that you do because your work is in gynecological cancers.
Right.
But you've been working on some new drug combinations. Talk a little bit about what has been effective, what trends you are seeing in those kinds of cancers and their survivability.
I've been practicing for 38 years, so I've seen the huge improvement we have noticing cancer in general. In gynecological cancers, there's still a lot of need, but there has been great improvement. So ovarian cancer, for example, the average survival exceeds 5 years now, which was not the case 30 years ago. And there's a lot of new developments, particularly related to the immunology of ovarian cancer, including development of vaccines and new immune-based treatment. And the same is true for endometrial cancers and cervical cancers. So there's a lot of hope for the next 10 or 20 years that we're going to find more and more cures for these diseases.
And why is it that ovarian cancer is so lethal? I mean, kind of think of it on par with pancreatic cancer in terms of just being a death sentence.
So it's in part is because of the fact that when it's diagnosed, usually is advanced stage because of where the ovaries are. But there's very effective therapy, and cure has occurred or can occur in as many as 50% or more now compared to 20, 30 years ago, where that number may have been 10% or less.
I was on your Mayo site and I saw something that really just kind of stopped me in my tracks because it seemed more frank and unvarnished than you hear perhaps from your own physician. But it said, all patients with breast cancer and gynecologic cancer that has spread eventually die of their cancer.
Not all of them. We do cure some of them, but many of them, unfortunately. So there's a lot of need for additional research for breast cancer, ovarian cancer, gynecological cancer, and all other cancers.
But ultimately, you're looking at kind of a delay in the lethality of the metastatic cancers.
No, actually, we do cure
Mm-hmm.
some patients who have widely metastatic ovarian cancer and breast cancer with the newer treatments that are available. So we always give that hope to the patients because that's a real thing. They can be cured.
Mm-hmm. I want to ask you about environmental causes for that, and I would like to hear from Dr. Lee as well, but particularly for some of those gynecological cancers, we hear about environmental causes, whether it's, disrupted hormones because of pollutants in the environment. Recently, there was a lot of news about baby powder perhaps being a contributor to ovarian cancers. Do you see much in the way of where finding a more specific reason that those cancers occur?
So for ovarian cancer, we know there's a significant genetic component. And in terms of what environmental factors are playing a role, we still don't have a clear idea. There's controversy about talc, whether it had contributed to ovarian cancer or it doesn't.
Like in talcum powder?
Talc powder use. But there's a lot of research going on and a lot of development that has had a huge impact on ovarian cancers.
And Dr. Lee, since you came at science from an environmental perspective, how do you see that conversation now that you're, on the medical side? Do you see much interaction between the world of environmental research and the world of medicine?
Yeah, I can't comment specifically on environmental contributors to gynecologic illness, but I think that's a trend that I've seen in lots of research in different areas. For example, in urology, there's a lot of study of how someone's gut microbiome or microbiome might be able to influence some disease processes. So I think there's definitely interplay, and there's like the study of epigenetics as well, so how the environment or someone's circumstances might influence your genetics and have that be passed on. I think that's definitely an area of research that a lot of people are interested in.
And so tell us a little bit about your days now as you move forward into your residency. We always hear about long hours, kind of crazy round the clock. Is that accurate? Is that what you're going to be living now?
Well, for now, I was telling Dr. Colon Otero, I have a little bit of vacation, which is insane. I don't know what to do with all this time. But beginning June 24th, July 1st, I'll be starting residency. The hours are pretty variable depending on what service I'll be on. So if you watch Grey's Anatomy, I know people rotate on different services like cardiothoracic surgery or the intensive care unit. So Grey's Anatomy isn't completely right in that I won't be rotating through services that aren't pertinent to my training, but the hours are pretty intense. The governing board for residency, however, has recently set a limit in terms of workable hours, so we won't be working around the clock like some former physicians may have.
Yeah, and so what are reasonable hours? What is the definition under that new established guideline?
Yeah, I believe it's under 80 hours per week, and that's still a lot of hours, but I think I've always thought that sometimes you need to get the repetitions in order to see the dividends, and that's definitely true in surgery, which is a physical act. So 80 hours or less.
And so how long is it before you actually are able to wield a scalpel?
Day one.
Wow.
So under supervised practice, you're allowed to help participate or help assist in surgery even beginning in your clinical years in medical school. So if I feel ready and if my preceptors or the doctors I'm working with feel that I'm ready and have demonstrated the capability and the knowledge, they'll let me start helping on day one.
Is that nerve-wracking for you personally?
It's nerve-wracking. It's a massive responsibility, but it's also really exciting because this is what I've been waiting and training and studying for.
And Dr. Colon Otero, how do you help somebody like Dr. Lee make that transition from, exploring all of this from a purely academic side to really being in the field with patients, before you?
Yeah, that's a great question. So as part of the medical school training, they actually are exposed to patient care early on. And as the medical school curriculum has changed over the years, we expose them earlier. And we make sure that by the time they finish their medical school, they had all those experiences. We use simulation. We had a fantastic simulation center at our medical school where they practice using fresh cadavers. And so it's not like when they are resident, they haven't been exposed or they haven't done surgery or participated in surgery. So they are well trained as it relates to all that. And part of their training is actually related to doing preparation for residency. So where they're actually functioning as an intern already or functioning as a resident during the last year. And that sort of prepares them perfectly for the residency.
Do you look at these new guidelines that limit some of the hours that they have in residency? Do you think that this new crop is just going to be soft because you had to do so much more?
No, I think they are very appropriate to have those guidelines so that they are rested. But there's no question residency is a very taxing procedure because they get to work extremely hard and taking care of the patients under supervision, which is great.
Well, Dr. Colon Otero and newly minted Dr. Lee, thank you both so much for being here today. We appreciate it.
Thank you for having us.
Yeah, thank you for having us.
And good luck with everything.